Okay, it's I think just a minute or so after 12. Let's go ahead and get started. Today, I'm going to give a presentation on healthcare economics, and in particularly looking at cost effectiveness analyses. So in terms of my outline here, what I'm going to focus on is cost effectiveness with patient level data. You can do what's called microsimulation, where you have data from patients, but the analysis itself is on a simulation of different scenarios, different possibilities. So obviously, what we need to discuss is where do we get the cost from, and how do we assess effectiveness. And so we'll then talk about the statistics related to cost effectiveness, and then talk about how we do sensitivity analyses. And then I want to end up by giving an example of a cost-effective analysis in an observational study. So in terms of medical decision-making, costs have become an important factor in that. And the idea here is, of course, that there's some new treatment or therapy or whatever, medication that's going to improve health or quality of life, etc. But typically that new treatment comes at a higher cost than the previous standard of treatment. And so one of the primary concepts that we're going to talk about or going to address is the willingness to pay. How much is an individual or society willing to pay for the improvement in health? And the two primary pieces of data that we're going to need, as I mentioned, are first of all the outcome from the study. And so this is usually we're going to talk about survival, or we can talk about life years gained, or the primary outcome that people use, or at least present in studies, is what we call quality adjusted life years. And I'll talk a little bit about that in more detail, but basically a quality is calculated by multiplying survival by a utility, which utility is a measure of health status. It's scaled from 0 to 1, with 0 meaning death and 1 being perfect health. And then, of course, we need data on the cost of the treatment or procedure or medication, hospitalizations, different things that might go into estimating the cost of a treatment. So when we estimate patient level costs, there's different ways of doing this. A UB04 is, I think that's a list of hospital itemized cost, but that's fairly difficult to get. We can find published reimbursement schedules. For example, in the US, there's what's called diagnosis related group. And so this is a procedure, and a particular outcome that's been assigned a cost. And the corresponding idea in Canada is what's called a case mix group. Or we can get costs from Medicare, Medicaid data. Medications, there's published what's called a red book of wholesale cost. Other sources, there are other sources of getting costs of medication. So what do we cost in a cost-effective analysis? Well, usually we have a list of primary events. So here I've listed cardiovascular events that we would probably be interested in costing. A cardiovascular death myocardial infarction, stroke, so on. We'd also want to cost serious adverse events like bleeding, syncope. There might be others that we would want to find the cost for. Then also there would be potential subsequent hospitalization. So maybe a patient after the procedure or the trial ended had heart failure, or during the trial had, say, for example, was hospitalized for heart failure. Then there are physician costs, which are usually separate from hospital costs. Then we might have follow-up care. Is there rehabilitation cost involved? And then, of course, we would need to cost any medications, statins, for example. And then sometimes, at least in the past, so sort of indirect costs like lost wages have been calculated, but usually that's really difficult, very difficult to estimate. So you don't really see that as part of cost anymore. So here's an example from the CREDO trial, which is quite a few years ago when clopidogrel was in the news, was being looked at in cardiovascular literature. And so I have several DRGs here, what it is. So for example, like the first one, 116, is a pacemaker implantation or an artery stent implant. And so in the CREDO trial, we listed the number of hospitalizations in each of the two groups, the clopidogrel group and the placebo group, and then what the cost was per procedure or event. And so this is one way of obtaining costs. Another one, a more recent one, on a study that we're actually working on now, where the primary events of interest have been cost by age group. And so, for example, we have a fatal cardiovascular event by ages 45 to 64, 65 to 84, and then greater than 85. And so there's, these have been estimated from a particular source, in this case, what's called the National Inpatient Sample. And whenever you get costs, you have to, obviously where you're getting them is important. So that's why we have a reference over here as to where we're getting these costs from. You can't just, make them up. Although I suppose one might argue that that's what's being done anyway. But regardless, we have a mean cost. So that's of patients in this age group, the mean cost for a fatal event was almost $19,000. And of course, there's variability associated with that. And so we have the standard deviation and then minimum and maximum for this particular age group. And then so the same thing for an event from an MI by age group. And so one thing you notice that we present in this table is the distribution. So how is cost distributed? That is, if you were to do a histogram of cost, what would it look like? And typically, costs are assumed to come from what's called a gamma distribution. And it's certainly not a normal distribution, because if you do a histogram of costs, it's typically right skewed. And of course, this occurs because you have most of the cost in a particular range down here, but with any procedure or subsequent hospitalizations, complications, whatever, there are extreme costs, in which then gives us this long tail in the distribution. So we model this as a gamma distribution. So you might ask, well, why don't you do like a log transformation or something like that. Well, the problem is you can transform this all you want, but you still come up with a skewed distribution. So we're going to model cost as a gamma distribution. So then utilities, so utilities are a measure of patient quality of life. And as I mentioned before, it's scaled from 0 to 1. And these can be patient reported. In fact, many studies obtain this information during the trial via some published instrument. The primary one, or the most common one you see, is called the EQ5D. So this is a 5-item instrument where the patient rates the different aspects of the quality of life, and then it's scaled to range from between 0 and 1, with 0 being death and 1 being perfect health. If you have a study where it's not, you don't have this information, it's not patient reported, then what we do is we estimate it from published literature where the sample would be similar to what we're doing, and usually similar, we mean just similar in age and sex. But if we don't have that data from individual patients in a trial, then we can estimate it from other sources. But of course, just like cost, we have to tell our readers where this is coming from. So there's always reference, as we have here, for utilities. And so again, from a recent study that we're working on, we have utilities for different cardiovascular events, whether they have a history of them. So if a patient has no history of a cardiovascular event, then their utility is 1. So in one sense, everyone starts out with a value of 1. But if they've had a history of, say, for example, stroke, then the utility is decreased, and it's like 0.88 in our example here. Or if they have a history of both an MI and a stroke, that's even lower. And then we have what's called disutility. So disutilities are applied if a patient actually experiences an event, or in this case, a revascularization, a bypass, or a PCI, percutaneous coronary intervention. And so depending on whether or not this occurs during the trial, they have a subtraction of this value. And so the utility values, we're going to assume that they're distributed as a beta distribution between 0 and 1. And again, as I mentioned, we would indicate where we got this information from that we're using in our study. And so just to give an example here, so let's say we have a survival, or it could be life years gained. So how do we calculate a quality adjusted life year? Well, it's just the utility times the life years, or the survival. So let's say, for example, that we have a patient here that has a survival time of 4.5 years, but they've had before the trial began, they had a stroke. They have a history of stroke. So we multiply their survival times the utility, which from the previous table was 0.88. So we now have a quality adjusted life year of 3.98. And then let's say that they had a non-fatal stroke during the trial. So that means that we're going to subtract a little bit more from their quality adjusted life year. So we come up with 3.97 qualities, or 3.97 quality adjusted life years. Okay, so that's where the primary the primary effectiveness is expressed in terms of qualities that you will see in the literature. So And this is probably one of the most important slides is this is the statistic that we come up with in cost-effective analysis called the incremental cost effectiveness ratio, or the Icer. And it is the mean cost of treatment A minus the mean cost of treatment B, and that's divided by the mean effectiveness in A minus the mean effectiveness in B, or the mean delta, or the mean difference in cost divided by the mean difference in effectiveness. And so what the Icer means is that if we say, for example, have an Icer of $50,000, that's what our Icer turns out to be in our study. What does that mean? Well, that means that we're willing to spend $50,000 for one quality gained, or one, say, life year gained. And you say, well, where does that come? Where did you get that figure from? Well, it actually dates back to a congressional hearing quite a few years ago on the cost of dialysis. And it's sort of the standard that's used in US cost effectiveness. But of course, that's arbitrary. It can be used, or different values can be used. But that's basically what it means, what the Icer means. It's whatever it turns out to be, that means the amount of money you're willing to spend for one quality gain or one life year gained. And so that brings us to the concept I mentioned before, willingness to pay. How much are you willing to pay for one life year gained or one quality gained? And to some degree, that sort of depends on your perspective. So in most studies are done from what we call a societal perspective, but there might be other perspectives where a willingness to pay would be quite different. For example, an insurance company might have a different idea of what they're willing to pay for a gain in one quality or one life year. So when it comes then to doing statistical analysis of the Icer, what are we going to actually do here in terms of the analysis? So it turns out, of course, if you look at the formula there for an Icer, that it's basically a ratio of differences in means. So we might have Icers that could have the same sign, but they would have different meanings, different interpretations. So what we're going to do is we're going to need to find a sampling distribution for the Icer. And remember, we assumed costs were going to have a gamma distribution, utilities were going to have a beta distribution. So how are we going to come up with a distribution for the Icer? Well, as it turns out, we're not really sure if it fits any of the sort of kind of standard distributions like a normal distribution. So what we're going to do to get a distribution is to do bootstrap resampling with replacement. That means that every time we draw a random sample from our data, it's going to be put back in and for the next draw that we make. So what we do is however many, whatever our sample size in our study, we draw the same number of random samples as the number of patients or observations in the data, and then calculate the statistic of interest. So we do this, of course, bootstrapping, you do that a large number of times. We usually do it 5,000 or 10,000 times. And this gives us a distribution of the statistic of interest, or the Icer. And so to sort of illustrate this with a picture here, we can then plot our Icer in what's called the cost effectiveness plane. And so on the horizontal axis here, we plot the effectiveness within going from left to right, increasing effectiveness. And on the horizontal axis, we plot the cost, going from least cost to higher cost. And so the cost effectiveness plane we divide into 4 quadrants. And quadrant 1 over here is called the cost effectiveness quadrant. And so that's the quadrant where we have higher costs, but also we have more effective, it's a more effective treatment. So both costs are increasing and effectiveness are increasing. In quadrant 2, we have the situation where we have better effectiveness, but at lower cost. And of course, quadrant 2 would be the ideal that everybody wanted to end up with in their study. In this case, we don't really report the incremental cost effectiveness ratio because, as we'll see, it's negative, but we call lower cost and more effectiveness dominant. In other words, whatever treatment we're looking at is dominant. That is, it's more effective and costs less. Quadrant 3 is where it's cost less, but effectiveness is not as good either. And then quadrant 4, which is sort of the worst case scenario where the new treatment costs more, but it's actually less effective. And so in this case, we say that the new treatment is dominated. And so I have put some numbers in here to sort of illustrate these ideas. So over here in quadrant 1, we have, say that our new treatment cost is $500 and the standard is $200, and our effectiveness is 0.5 qualities in the new treatment and 0.2 in the standard treatment. And so here, A is more costly, but it's more effective. And so our cost effectiveness ratio here is going to be $1,000. In quadrant 2, the cost is just reversed. So now the treatment again costs more, but it's also more effective. So now we have the same numerical number of $1,000 here, but it's a negative $1,000. And so here in this case, the treatment, the new treatment or treatment A is dominant. It's cheaper and more effective. And then with the quadrants 3 and 4, we can see how this turns out computational wise, where in quadrant 4, then we have a more expensive treatment, but it's also less effective. So you can see that there's different interpretations of the cost effectiveness ratio depending on what quadrant our bootstrap replicates fall into. And so here's an example of how this is plotted out. So we have effectiveness here on the horizontal axis, cost of difference on the vertical axis. And so here's our 5 or however many thousands of points bootstrap replicates we've drawn. And so we can see that most of the bootstrap replicates fall into quadrant 1 in this case. There's a few in quadrant 2 and a few in 4, very few in 4. And so what we plot then is this in the cost effectiveness plane. We put in the horizontal and vertical axis here so we know which quadrant we're in. And then the diagonal line here represents whatever our willingness to pay threshold was. So in this case, it's $20,000 per life year gained. And so what this means is that all of the bootstrap replicates below the diagonal line here represent better results, but at higher cost, or so that all of the Icers in this below this are $20,000 or less. We can also then plot this information in terms of what's called the cost effectiveness acceptability curve. And so we have our cost effectiveness plane here. Oops, I went skipped one. Our cost effectiveness acceptability curve. So where we plot here are thresholds or our willingness to pay thresholds from 0 to whatever on the horizontal axis, and the probability of being cost effectiveness on the vertical axis. And this ranges, of course, from 0 to 1. And so, for example, in the cost effectiveness plane that we looked at, its corresponding cost effectiveness acceptability curve is plotted as a probability against the willingness to pay threshold. And so here you can see it, if at $50,000, we're well above probably 0.9, even 0.95 a probability that it's cost effectiveness at $50,000. At $20,000, here you can see that it's also probably 0.9, at least 0.9 probability of being cost effectiveness at an Icer of $20,000. So here's a couple of examples just to show some differences. So here's a study where it was actually the new treatment was dominant. That is, virtually all of the Icers fall into quadrant 2. So you can see here, here's quadrant 1, here's quadrant 2, 3, and 4. So this, what was being looked at here was a dominant strategy at more effective and but at lower cost. And then here's an example that you really wouldn't want to see, where we can't really say much because we have a large number of our bootstrap replicates kind of falling in all of the quadrants, probably the most being in quadrant 4. So here we would really have probably no benefit at all to whatever our new treatment was. So the other concept, or another concept I need to talk about, is discounting. And so this is the idea that the value of quality or life years gained diminishes over time. In other words, it's more important, qualities are more important closer to the study than they are over or to receiving treatment than they are longer out in the study. So what we do is we discount, and if we have, say, like a 5-year study, in the first year we don't discount at all, but in the second year we'd start to discount. And so discounting is calculated. In this case, I'm discounting 3%. So this is what it would look like, 0.03 being the discount percentage, and then it's raised to whatever year we're assessing. So this would be the discount in the second year, this would be the discounting in the third year, and so on. And we discount both qualities and costs in our cost effectiveness study. Okay, so then what we need to do once we calculate what our cost effectiveness outcome is, we need to do some sensitivity analyses then, because as you saw from the previous slides on cost, as well as qualities, that there's variability in these estimates of cost. And so we need to demonstrate if there's how much of a difference would be found if the cost was different from what we actually used. And the cost we use is the mean cost. And I forgot to mention, we call that our base case. But because this cost can vary, then we need to have some idea of just how robust our conclusions are, or if it's a different cost, are we going to get something, we're going to have a completely different result than what we got. And so basically what we're doing is we want to determine whether our results are insensitive to substantial but plausible variations in a parameter, being cost or utility. So there's different types of sensitivity analysis. A one-way sensitivity analysis is where we vary just one parameter like cost. And so typically we might vary cost from our base case for 10 to 20% less or more. So for example, we would look at, say if the cost was 20% less than what we estimated to be, or it was 20% more, what would our incremental cost effectiveness ratio look like? Sometimes then you'll see two-way or bivariate sensitivity analysis where you vary two different parameters, cost and utilities. And then there's obviously such a thing as a multi-way, where you vary a number of different things that might influence cost and utilities. But of course, once you get beyond a two-way, it becomes very sort of difficult to actually do that in practice. And so what we do then is what we call probabilistic sensitivity analysis. And for those who were at the session, I think a couple of months ago, where we did Bayesian analysis, you'll recognize this, and I'll use some of the same slides as I did there before. And then we also will do what we call scenario analyses. What if the treatment effect only lasts 1 year? Or we might, so then we would do an analysis that the treatment only lasts a certain amount of time. Or we might say, what if patients stop taking the medication, for example, after 1 year? What would it look like then? So that's what we mean by a scenario analysis. So let me talk about the probabilistic sensitivity analysis. As I used this example earlier when we talked about Bayesian analysis, that basically what we do is we're going to draw a random value from the distribution that we proposed for our cost or our utility or whatever else we might be wanting to cost. And then we calculate the Icer with the particular values drawn. We do that a large number of times. And then we can look at the distribution of what the plot of Icers would look like, where we have been able to draw simultaneously different in the particular parameters. And so this is an example from a Courage study that we did some time ago, where we have effectiveness, utilities for different events, and then we have costs for different events, revascularization or hospitalization, medications, and so on, and a distribution. And so if you remember when we talked about doing a Bayesian sensitivity or probabilistic sensitivity analysis, what we're doing is now we're not drawing from our data, but we're drawing from distributions. And so this is a slide I had before. So if we have, we're going to do 100,000, say, random draws from our distributions for a particular possibility that we might have for a patient that fits, that's in our database. But again, when we're doing a bootstrap, we're drawing from data. When we do probabilistic sensitivity analysis, we're drawing from distributions, which is a Bayesian analysis. So in my example here, I had a patient who, say, had a history of stroke or had a stroke. So we cost that had a stroke during the trial. He was taking atorvastatin during the trial. So we draw from our cost, our gamma distributions for cost, and then let's say the patient had a history of angina. So we would draw a utility from this particular distribution. And so we do this, again, a large number of times. And so we get a difference in cost divided by a difference in qualities. And then we then plot this to see what our distribution would look like if costs were varied. And so for the, and I showed this plot, I think before, this is from our COURAGE study. And then the different probability assumptions were derived from different sources, the American Heart Association and the Cardiovascular Health Study. And then when you do the simulation, that's what is called a Monte Carlo simulation, and to derive the differences in qualities and the mean cost between, say, two treatment groups, which in COURAGE was percutaneous coronary intervention versus optimal medical therapy versus OMT alone. And so we get this plot, a contour plot here, where we have the joint distribution of effectiveness and cost, where we have sampled from the different distributions. And so our inner ellipse here is 90% of the simulations fall in here. Our middle ellipse is 95% here, and then the outer is 99%. So we can see how much variability we can get based on drawing from the different theoretical distributions. Okay, so then in terms of cost effectiveness that's in trial, we can also then look at cost effectiveness beyond the study period. And so we use our in-trial data to project beyond the study period. And so there's different quantities now that we have to estimate to look beyond the study period. And so one being the time horizon. So do we want to look 10 years after the end of the study, or oftentimes a lifetime horizon is used. And then we need to estimate life expectancy beyond the trial period. So there we would need some life tables that for life expectancy over an age range of, whatever. In the past, we used to use the Framingham data, but I think there's more up-to-date ways of doing this now. And then we'd also need to figure out the probability of events beyond the trial period, which again, you would need some sort of life table for events, for example, stroke or MI or whatever the event might be that you're interested in. And then we also do the same thing as far as discounting is concerned. Typically, discounting might be no discounting. We typically use our base case as 3% discounting, and then sometimes I've seen discounting up to 6 or even 10%. So I want to then look at a particular study that we did just a few years ago that was actually an observational study. I think I used this study as an example when I looked at or the data when we looked at Bayesian analysis. So as I mentioned before, when in another session when we talked about propensity analysis, that in an observational study, we're going to have to do something to reduce selection bias. And so the two ways of doing this that we talked about before was we can match based on the propensity score, we calculate, or we can do an adjustment, a weighted adjustment like the inverse probability weighting. And then we would need to do some analysis of or some sensitivity analysis of what would happen if there was a confounder that was unmeasured, that we didn't actually get in our data. So the study was, I said, published a few years ago, where we looked at the cost effectiveness of revascularization strategies, in particular bypass, coronary artery bypass versus PCI, percutaneous coronary intervention. And so this was a study that I used the data before in looking at propensity scores. But we also did a cost effectiveness of revascularization strategies. And this was actually a very intensive computational statistical analysis, which is reflected in that for your interest here, the first 5 authors are statisticians instead of clinicians. So this was the comparison of the 2 groups, CABG versus PCI, with respect to a number of baseline characteristics. And then you can see that of course, as one would expect, they would differ on almost every variable. And then I think this was a slide I showed before, which didn't turn out too clear here, but this was after we did inverse probability weighting, and then where we did matching. And so what we are going to do then, what we did is do a cost effectiveness analysis based on the inverse probability weighted and the matching data, which of course you can see that when you match, you have quite a fewer number of patients to analyze than you do with the weighting adjustment. And so this is what our results look like here, where we have life years for the study from 2004 to 2008. We have the difference in costs, CABG minus PCI in this case. We have life years gained with CABG, our incremental cost effectiveness ratio, and then we also present the percent in our either bootstrapping or in our lifetime analysis of the percent that are dominant and the dominated and the percent that are dominant. And then we usually look at the percent of bootstrap replicates that are, let's say, less than 30,000, less than 50,000, or less than 100,000. These can vary depending on what you want to do. So what this means is that for example, where we looked at life years and did 3% discounting, and with the adjustment here, I'm not going to go into the adjustment here. This is another a little more complicated way of adjusting the propensity scores. But we have a difference of $8,000, 0.3 life years or qualities gained, or this is life years. And then the Icer turns out to be just, this divided by this, which is $26,000. And so what this means is that 70% of our bootstrap replicates were below $30,000 per life year gained. And then we do the same thing for lifetime analysis and then quality adjusted lifetime analysis with discounting. And then we did then the same sort of analysis here with the matched population and got fairly similar results. So here, for example, the lifetime with 3% discounting, a difference of $12,000, life years gained of 0.3 plus. The Icer and then the percent of replicates that were dominated or less than some given threshold. So when we plotted this in the cost effectiveness plane, then it looked like this. So you can, this is, looks a little funny here because typically when we do a plot like this, we want to make sure you know which quadrant you're in. So we try to have both the intersection here of zero effectiveness and zero cost difference. So you can see that most of the replicates here were right at $30,000 per life year or per quality gained in this case. And so our conclusion was that, or before we do our conclusion, then this is the cost-effective acceptability curves for both the match data and the IPW adjusted. And they're fairly similar here, although you can see for the matched, it's much more pronounced here. But of course, you have less data here for the matched data. But you can see that basically we have well over 90% probability of it being cost effectiveness at $50,000. And then so we concluded that over the period of 4 years or longer, that patients undergoing CABG had better outcomes, but at higher cost than those undergoing PCI, and that it was cost effective at thresholds between $30,000 and $50,000 per quality gain. Okay, so the final thing that I want to mention here is that that many cost effectiveness or many trials are done from different healthcare systems, and that is patients are being enrolled from different countries. And so what we've done is that we assume that the results are same regardless of which country or which healthcare system came from, but of course you can't assume the same costs. And so what we do is we take costs from a single country and then do the analysis for the costs from a particular country. And so, for example, where we can readily get costs, of course, are in the US and Canada, the UK, the EU, and Australia. It's really difficult to get costs from other countries. But you might say, well, why don't you use costs for each country? Well, the problem is if you do that, then you have a cost-effective analysis that doesn't apply anywhere. So in terms of the situation where we have a trial that has enrolled patients from different countries, we cost from one country, and so that means, of course, that we would have to get costs from, say, for example, not only the US, but we would need to have Canadian cost or EU cost. So that's basically the idea of cost-effective analysis. It's a sort of fascinating area of, or analysis to do. And of course, the primary, I guess the big burden of this analysis is coming up with costs and utilities. In doing a cost-effective analysis, you have to be straightforward or upfront about where you're getting your estimates of cost and utilities from. Okay, so these are a few publications, if you're interested, of cost-effective analysis and how it's presented in literature. And then in terms of our next session, our next seminar on May 21st, we're going to have a presentation by Christian Boxley on using Tableau. And I think you'll find this quite an interesting presentation. And then we're going to take a summer break, June, July, and August, and then we'll resume the seminar in September, on September 17th. So again, thank you for your time and attention, and hope that you enjoyed these sort of fascinating area of cost-effective analysis alongside clinical trials. So let's see, I think it looks like there's a few questions here. Let me see if I can. Okay, so there was a question of beta and gamma distributions. So these are theoretical distributions. As the sample size increases, or the number of patients you have, these distributions tend toward a normal distribution. There's a mathematical formula for each. I don't have that handy, but you can sort of look them up. But they're defined by, like a normal distribution is defined by two parameters, its mean and its standard deviation. And in the same way, beta and gamma distributions are defined by, I can't remember which ones, but there's three parameters that define distributions: the central tendency, the mean, the variability, the standard deviation, and then there's I think what's called a scale parameter, and I don't remember which ones. But so where we get the different distributions, we would have a cost that has a certain mean and standard deviation, and so we would then use that gamma distribution. And so each event or each event that we cost would potentially have a different gamma distribution. So we would draw from the relevant gamma distribution for that particular cost. Let's see, then how do we estimate or calculate effectiveness of treatment A over treatment B? So that's, if you look at the formula for the incremental cost effectiveness ratio, that's just the difference in the mean effectiveness minus the mean effectiveness in the other treatment. So if we define that in terms of quality adjusted life years, the difference is just that. It's the quality adjusted life years from treatment A minus the quality adjusted life years from treatment B. Okay, the other questions here are just straightforward. How there's a recording of these webinars, and they will, let's say, I believe the link I think they come up on YouTube. I think the link to those is sent out by Georgetown shortly after, here in a day or two after the presentation. And then the slides to registered participants. Okay, I'll talk to the Georgetown folks about having those, how we can send those out. So any other questions? Okay, if not, oh, let's see. Okay, let's see. Someone raised their hand. How do I get to that? So I guess, Noir, is it possible to unmute someone who raised their hand who has a question?
Let me try, hang on.
Okay.
I'm afraid I'm unable to, and I think maybe typing in the chat box is what we've got right now.
Yeah, okay. Let's see here. So if you didn't get a question, or you have other questions, or didn't get your questions answered, let's see. Go to the there. You can just email me.
There is answer live. Let me see if I click on answer live. Who's trying to ask a live question? Is it Megan or?
I'm not sure.
Let me see if I can click answer live. Nope, I don't think that's gonna work.
Okay.
All right.
All right. Well, sorry about that. So again, if you have another question or have other issues that you'd like to discuss related to this, you can just email me at my MedStar email here. So again, thank you for your time and attention, and we'll see you next month.